This PowerPoint presentation will discuss policy and policy solutions in regards to African American health disparities. Buford Longest Jr. defined health as the state of complete physical, mental, and social well-being, and not merely the absence of infirmity. In trying to reach an optimal state of health, by 2027, the United States is expected to spend 19.4% of its GDP annually on healthcare. That is roughly $6 trillion. It spent 17.9% of the GDP on healthcare in 2019. While the United States spends more than any other developed nation on healthcare, it is not the healthiest country. In fact, there are many other countries that spend much less and have better health outcomes. In spite of its spending, the United States still has lower life expectancy, higher rates of obesity, and higher rates of maternal and infant death. In addition to the United States as a whole falling behind in health metrics, there are several groups and subgroups of people of color that experience even further unacceptable disparities in the quality or versions of healthcare that they encounter when compared to Caucasians in the general population. One such group is African Americans. Historically as a whole, African Americans have lower health status, lower health outcomes, less health insurance coverage, and lower utilization of care as compared to non-Hispanic Caucasians. The following are just a small handful of sobering statistics. Babies born to Black women with doctorate or professional degrees are about 3 times more likely to die than babies born to white women with only high school diplomas or GEDs. From 2011 to 2015, the incidence rate of prostate cancer for African American men was 179.2 per 100,000 and 101.7 for non-Hispanic white men. In addition to the higher incidence rate, African American men were 3 times more likely to die from prostate cancer. In regards to HIV, African American women are 22 times more likely to die from disease-related complications. African Americans ages 18 to 64 have a greater risk of early death than whites. African Americans ages 35 to 64 have double the risk of high blood pressure as whites. African Americans ages 18 to 49 are twice as likely as whites to die from heart disease. African Americans also have a 3 to 5 times higher share of confirmed cases of the coronavirus and are 3 to 6 times more likely to die from it. There are many health determinants that work singularly as well as systematically in complex ways to affect health outcomes. An important influential factor in optimal health is personal behavioral choices. However, behavior is greatly affected by external stimuli. Health policies exist to influence, maximize, and control determinants and factors that affect health. Unfortunately, in spite of the many laws, regulations, guidelines, and protocols that exist in the private and public sector, African Americans are still faring negatively in comparison to the general population. While the United States ranks first in healthcare expenditures, it ranks 25th in spending on social services. Social determinants of health include things such as race, housing, poverty, income equality, and gender. These determinants influence mortality, morbidity, and risk. A response to positively change these determinants is policy. According to Buford Longest, policies are officially or authoritatively making decisions for guiding the actions, decisions, and behaviors of others. Public policy is specifically those policies that are made by governmental or legislative action. For decades, racism has been a systemic social factor and determinant that has direct causality to African American health disparities by exclusion, discrimination, and in ways that cannot be empirically measured. Racism has led to economic disadvantage, educational disadvantages, housing challenges, and even long-term physical damage, since racism has been proven to be a stressor that puts wear and tear on the body and mind. There have been attempted policy solutions to deal with racism. Two of those were the Civil Rights Acts of 1964 and 1968. As a result of those acts, African Americans have been able to make some positive societal gain. However, as a group, they are still paid less than Caucasians and are far behind in regards to wealth accumulation. In spite of educational gains and a small amount of social mobility, African Americans remain one of the most economically disadvantaged demographics. Socioeconomic status is directly correlated with healthcare outcomes, environmental effects, and health behavior. In the past, there have been policy attempts specifically aimed at African American health. In 1984, Margaret Heckler was the Secretary for Health and Human Services. She conducted the first comprehensive examination of African American health disparities. In 1985, she released the report of the Secretary's Task Force on Black and Minority Health, which became known as the Heckler Report. As a result of her work, the Office of Minority Health was created in 1986. Its purpose was to create policy to end health disparities. There has been expansion to the Office of Minority Health, including the establishment of offices of minority health in other government entities. Unfortunately, 35 years later, African Americans still suffer disproportionately from health disparities and do not have the political power over policy to make change. Presently, one of the most influential and sweeping examples of healthcare policy is the Affordable Care Act. The ACA was passed by a Democratic Congress and signed into law in 2010. Republicans opposed the legislation then and are still attempting to dismantle it. The enactment of the ACA is policy creation described by Buford Longest as punctuated equilibrium theory. This theory states that policy making happens in small incremental steps that can be disrupted by rapid transformation. The ACA created many different offices, institutions, governmental departments and programs, healthcare industry regulations, and insurance reform. One of its most controversial yet positive manifestations was the creation of healthcare insurance exchanges in 2014. African Americans were lagging behind in healthcare utilization and access. The healthcare exchanges, in combination with other legislation, such as Medicaid expansion, results in African Americans obtaining greatly improved levels of insurance coverage and improved access to medical care. This has resulted in markedly improved health outcomes. However, African Americans still have stark disparities and inequalities of healthcare. Even when you analyze the African American demographic controlling for socioeconomics, education, and quality health coverage, large discrepancies and inequalities still exist. This indicates that there are other factors that need to be explored. Improving health disparities is discourse that usually focuses on failure of personal behavior risk factors. I would argue that much more work needs to be done to comprehensively research institutional structural issues with emphasis on health system level failures and provider level failures. Racial bias has even been shown to be built into algorithms of software that some health facilities use to make decisions on care delivery. One company called Optum discovered that racial bias was inadvertently baked into its software algorithm that was based on health costs, which results in inaccurate gross mismanagement of the care of African American patients. Additionally, studies have shown that on a provider level, conscious and subconscious racial bias influences patient communication experiences and even medication prescription. The only way to dig deeper into health system level and provider level challenges is to gather data. There needs to be comprehensive and standardized data concerning healthcare bias and system failures, specifically in regards to race and ethnicity. Lack of data collection standards makes it impossible to accurately collect, report, and track such data. Affordable Care Act has resulted in the establishment of offices of minority health within 6 agencies: the Agency for Healthcare Research and Quality, the Centers for Disease Control, the Federal Drug Administration, the Center for Medicare and Medicaid Services, the Substance Abuse and Mental Health Services Administration, and the Health Resources and Services Administration. Within the Health Resources and Services Administration, also known as the HRSA, there is a Bureau of Primary Health Care. This bureau governs what it calls the Health Center Program. Health centers are community-based, primary care-focused, patient-centered organizations that provide care that is culturally competent and facilitates access to many other services for populations that have limited access. These health centers receive federal grant funding as well as funding from Medicaid, Medicare, private insurance, and patient fees. To continue to receive funding and keep government support, these health centers have to report their performance yearly with what the HRSA refers to as their UDS, or Uniform Data System. This reporting system is standardized, detailed, and requires a focus on multiple metrics, including a focus on minority health disparities. I propose that the Bureau of Primary Care be expanded to create more health centers, as well as create a national standard for all healthcare entities with which to provide their data based on the blueprint of the Uniform Data System. This act would force all healthcare institutions to create their own process for recording data on healthcare disparities in their system. This would result in self-discovery of systemic issues that need correcting in provider level factors and influence African American healthcare. Such a change would be a drastic shift of healthcare operations since it would require a paradigm shift. The shift would be a switch from looking externally to internal analysis and patient-centered value. Enabling legislation of this nature would require what Deborah Stone refers to as mobilization. Mobilization is when people understand their shared problems and organize to influence policy. Success will require organized and influential interest groups to pressure legislative agenda setting to make this a priority. Given that the current Republican majority would like to dismantle the ACA, convincing them that minority health disparities should be high on their agenda list is a daunting task. They need to be convinced that equality is compatible with efficiency. For all healthcare organizations to adopt a standardized and comprehensive practice of data recording would not just benefit African Americans, it would spur a great deal of improvement for the entire country.